This is the case history scenario. Mrs. S, 45 years of age, presents with a backache of 3 days duration. The pain was not radiating down the leg, no other joints were involved, and she has not had any problems related to the joints in the past. There is no numbness in the lower limbs, no bowel or bladder symptoms. She says the pain started after trying to carry some heavy boxes when she dusted the children's room. So here is a 45-year-old homemaker presenting with an acute backache after trying to carry something heavy. On examination, she was afebrile, in severe pain, and prefers to stand than sit in the consultation room. She is obese, BMI is 30.3, system examinations were normal, and examination of the back showed that there was generalized tenderness over both SI joints and also in the midline at the lower lumbar vertebrae. The SLR negative on both sides and the reflexes in the lower limbs were normal. So that's the case scenario. What I would like to now know, based on this information, would you like to share with us how would you move forward? Any takers, please?
Okay. You said she is 45 years.
Yes.
Married, no?
Yes.
But you said told about the bowels and the urinary problem. You didn't ask about menstrual problem regarding the wombs. I think it's important.
Okay, right.
One thing that I thought.
Okay. Any other views, thoughts, comments? Okay. Can you also just add on as to what else you would check in the history? I think Dr. Mota said one aspect that he would like to go into the menstrual history. Point well taken. Anything else? Use the mic, please.
You know, the postural problem is a very big problem. Whether when you said she did something in the bedroom.
Yes, she carried some heavy weights.
That's right. How really she did it without going on her knees.
Right.
That's the number one thing in this.
Right. Fine. Okay. Anything else? Anyone would like to add on anything else? Just would you like to think in terms of past history, family history, social history, her responsibilities? I mean, in those lines, yes, I mean, what you said is quite correct. Anything else you would like to add on? Okay, in the absence of any comments, the following information was obtained when further questions were asked. The past history, there was nothing significant other than a pregnancy-induced diabetes mellitus when she had the third baby. At the moment, no problems, and she said her fasting blood sugar, which was done about 6 months back, was 118 milligrams per deciliter. Family history, there's nil of note. In the social history, she shared with me that the husband is a heavy vehicle driver and often goes outstation. 3 children, 16, 12 and 8. First is a male and the other 2 are females. And they are living in a 2-bedroom house in the 2nd floor of an apartment. There are no lift facilities. And I just inquired into her daily responsibilities and also went into details as to her ability to follow advice given. She takes the 3 children to school, which is about 10 minutes walk from home. She washes clothes, no washing machine at home. And she also said that she does all the other household work, including mopping the floor. When I asked her briefly how she mops the floor, she squats and mops the floor. She doesn't have a mop with a long handle. So these were some of the details I was able to get at from her. Okay. Now I just would like to call upon our content specialist Dr. Lalit Vijayaratna to give his views and thoughts in regard to what we have discussed up to now. Over to Dr. Lalit.
Thank you, Shekhar. First and foremost, I want to thank the College of GPs for inviting me as a resource person to discuss this very important topic. And without wasting much time, I'll straight away with the problem. Now, whether you are a general practitioner or whether you come as a doctor at a tertiary care level, when a patient is presents to you with low back pain, what is your role? Your role is to manage this patient. And to manage the patient, you have to arrive at a diagnosis, which means that you have to try to work out what is the possible cause for the low back pain. And at the same time, like for any other disease, if there are any risk factors, we have to find out in our clinical assessment and address those issues as well in the management. Now, if one were to work out the probable or the possible underlying cause of low back pain, you must have a very basic theoretical knowledge on what can make a person to develop a low back pain. Now, if you look into any textbook called General Medicine, I'm sure you are very familiar with this list, the causes of low back pain. Now, when you go through this list, which is given in this slide, which you also get in many medical textbooks, I don't think as a clinician it does make any sense to us because it doesn't help us to approach the patient clinically. Therefore, today, we as people who take care of patients who have got musculoskeletal problems, we look at low back pain or we work out the cause of low back pain in a different manner, what we call as a clinical classification of low back pain. When a patient enters my room with this complaint of low back pain, I have to first find out to which category this patient will fall into. Because causes of low back pain from a clinical sense or from a clinical point of view can be grouped into three main causes. The first group is what we call as a dangerous cause. Why do you call it dangerous causes is that if you miss the diagnosis, if you delay the diagnosis, there will be death. So you have to take immediate action. So your primary role, no matter which level you are, primary, secondary, or tertiary, anyone with low back pain, first and foremost, you must always ask yourself, how sure am I that it is not a dangerous cause? Or are there features for a dangerous cause? Once that is excluded, you come to the second level. In the spine, you have joints. And the joints in the spine, like joints anywhere else in the body, like your knee, the ankle, your elbow, your shoulder, they too can undergo inflammation, and you can get arthritis of the joints of the spine, and that can give rise to inflammatory backache. And that is the second serious set of causes. Then you have the least serious causes, what we call as benign, which we see mostly among our patients, which we call as mechanical. That means too much of loading or too much of forces going through it, wear and tear, whatever you call it. So this is what you should do. Whoever you are, you have to always go through this list. Is it dangerous? Is it arthritis? Is it a mechanical cause? How am I going to do that? That's purely done by clinical evaluation. I want to emphasize the point that although today we talk about MRI, PET scans, and CT scans, none of them can categorize our patient to these categories. Today, even at this day and age, we talk about the importance of taking history. So therefore, when you get a patient with low back pain, a thorough clinical evaluation is needed. You tell the history. History is, as it has been discussed in some detail today, there's nothing that you can leave out. All the components in the history which we are taught when we were medical students had to be included. Sorry, I had not included the menstrual and gynecological history, which is also very important. I do agree with you, sir. So in the pressing, so these are the areas you cover, the same thing that you will cover in any medical history. Nothing you can leave out. Each and every subheading is important. And I will not go into much detail. In the pressing complaint, I'm sure all of you who have gone through medical school will remember when we were second and third year medical students, we were taught that whenever we get a patient with pain, there are 10 standard questions we have to ask for. Similarly, the same, so you have 10 standard questions that you have to ask from all your patients coming to low back pain. Why is this done? This is done in order to categorize your patients into those three groups. So you ask these, you analyze what you call as symptom analysis, or the pain analysis has to be done in great detail. And when I go through the case scenario given by Dr. Chandrasekhar, I see that this patient had a sudden onset The duration was very short. She came to us within 3 days, and there was a precipitating factor. She got this after lifting heavy box in her bedroom, and she said that there was no radiation. And there was a partial effect. She very clearly, though didn't say, when we were talking to her, we noticed that she preferred to be standing rather than be seated, which simply shows us there's a postural effect on lower back, and which is very important, which will help you to focus on which part of the spine the pathology is. So that's for presenting complaint. Then you have to do a very detailed systematic review, because low back pain can be caused not only by pathology or the spine, elsewhere too you can have people with low back pain. So you have to do a very detailed systematic review or review of the systems which you are taught in the medical faculty. And again, when I go through this case scenario, the important negative point is that she did not have any sensory motor symptoms, no numbness or weakness in her legs, which I thought was worth mentioning. Past history is also important. There was nothing of note in the past history. These are the questions I will ask from all my patients about the past history. There was nothing of note. Drug history is extremely important. You heard about osteoporosis and low back pain, 45-year-old lady, and she's reaching menopause. We don't know that she was on steroids for something or the other, and that can cause low back pain again. Family history is extremely important. We were talking about arthritis causing low back pain. There are certain types of arthritis which can run in family history or genes, so you have to ask for that. Osteoporosis, all of you know, has a very strong genetic influence. So if you say that my mother was suffering from hip fracture or my sister had a hunched spine due to osteoporosis, I strongly think of this condition. Social history, I'm very happy that great detail has been done. A very detailed analysis is needed. And going through her social history, we found that she was a very busy housewife because her husband was not at home. She had no helping hand. She had to do all the work by herself. She had a teenage son and 2 daughters. You can imagine how busy and how untidy the house would have been for her to clean the house. So you can imagine the workload she has got. She's almost single-handed. Her husband goes out of the house, so you can understand her mental state. She looks, I'm sure, a person of that nature with minimal help will be very anxious and depressed, and that itself can give rise to a lot of symptoms like backache. Recreation you must always ask, because recreation can be a preventive measure or it can be a causative factor for low back pain, and according to the details given, she had no recreation. So at the end of the history, if you have taken a good history, and if you extract the information you have taken, put it in front of you and analyze it, you can easily categorize our patient into these 3 categories. How are we going to do that? Well, the academic bodies today have very clearly defined what they call as red flags that you should look for in a low back pain patient. And if you have a low back pain patient entering your room, in your history, if any one or more of these points are present, that strongly suggests that your patient belongs to the first category. If you quickly glance through these, what I have given this slide, all these can be taken in the history. Now you can understand as to why it is important to ask about the past history and the review of the system. So quickly you go through that, and if any of these things are present, you have to very strongly think very carefully about this patient, because she belongs to the first category, the dangerous category. It could be either infection, it could be either a metastasis or a cancer, or it could be a fracture. These patients have to be immediately referred. So as a GP, if my patient had got any of these things, without betting eyelid, I'll give a call to the clinician whomever I'm in touch with. I straight away transfer the patient to a healthcare institution. I will not have to keep this patient with me. As I told you again, when you are assessing any disease, not only backache, any disease for that matter, one of our roles is to look for the risk factors. Why? Because if you do not address the risk factors, this person is going to get this again and again. So today there are well-defined risk factors which can cause low back pain. You have to have that in the back of your mind when you are, as a GP, you are going to manage this patient on a long-term basis. So what you do is very quickly, you just think back on the information you have extracted, whether there are any risk factors. And with the case scenario you are presenting today, there were 3 strong risk factors. Posture. She was a very busy housewife. Dr. Shekhar mentioned that even the mopping, she had to bend and do it. actually she got the backache while she was lifting a weight, which reminds us the amount of work she must be doing. She was fairly obese, BMI was 30.3, and you can imagine without any helping hand and the husband not being at home looking after 3 teenage children, the emotional distress she is undergoing, and these have to be addressed in a long-term management. So with that information history, we get on with the examination. I don't think I had to waste much time. Again, when you are confronted low back pain patient, you have to examine the patient all the 3 postures: standing, walking, and lying down. All 3 postures have to be looked into, because at each posture you can get a lot of information to focus on the point as to where the problem is and to find out the nature of the problem. So we'll start first with the patient standing. You unbrace the patient and you look at the patient from behind, and the first thing you look for is the symmetry of the spine, and if there is what you call as a scoliosis, which is a common cause of low back pain, particularly if you're obese and doing a lot of heavy work. You can see the asymmetry of the spine, which you can clearly see. You can see even if you can't see the spine, you can see the asymmetry of the shoulder blades, a lot of asymmetry you can see. Then if the low back pain is caused by a disc prolapse causing a radiculopathy or a sciatica, you can pick up by just simply standing behind the patient. Because if the disc prolapse is significantly causing pressure on the nerve root, they go into a posture what you call as a sciatic scoliosis or sciatic tilt. Then what happens is, as a result of the radiculopathy, the prolapsed nucleus pulposus pressing on the nerve, what happens is one side the muscles go into severe spasms. So you can see here, as a result of muscles going to severe spasm on one side, the spine is dragged to that side, and you can see a scoliosis. And one of the characteristic features of sciatica or lumbar radiculopathy is when there is significant pressure, you cannot bear weight through that leg. That's what I sometimes do in my clinic group. If they have pain radiating down their right leg, I ask them to stand on their right leg. They say, "Doctor, I can't." It proves that it's a significant compression or entrapment. And these are the characteristic posture they adopt. When you look at them from a side, you can see them that they are standing, holding their spine bent to a side, and you can see the side where the nerve is getting entrapped. They keep their knee flexed. You get the sense that they cannot bear weight from that side. I'm just trying to tell you how much information you can gather simply by looking at a patient, which is very important. Then look at the patient from the side. You have to always, I think I've told you so many times, you look at the lumbar curve, because if the lumbar curve is exaggerated, that can cause low back pain. If that is flat, that too can be a cause of low back pain. And today research tells us the main stabilizer, the main protector, the main structure which keeps our spine strong are the muscles or the anterior abdominal wall. So this is what we must always dream, to have a flat tummy. Flatter our tummy means that your muscles in the anterior abdomen is very strong, which in turn means that your spine is very well protected and guarded. So you have to look at, if that's a protrudent belly, that means your spine is vulnerable to various type of physical trauma. Starting with ladies, here you see the same lady. Just a little example, you can see the same lady, but the difference is she has got an exaggerated curve. And what's the reason? Wearing high heels. So wearing high heels, when you wear high heels, your center of gravity moves forwards, so your tendency to fall forwards, so your body up. There's a compensatory mechanism going on within ourselves, and our upper body curves back, and you get an exaggerated curve. So as GPs, I think you have to also look at their shoes when they walk in, what type of shoes they wear, and you can ask what the routine shoes they wear for routine practice, because high heels are a well-known cause for mechanical or chronic low back pain. That should be part of assessment. To be fair by the ladies, look at the men. You can see these two men. You can see here the basic difference is this is the ideal curve you should have, but you can see that the curve is very much exaggerated here. And I'm sure if you can talk to this man, he'll be in severe back pain. And you can look, if you look at these two men, you could look at their faces, you can see he's a very alert and a very active looking man. This man looks a very lazy man, always dining and whining. And that's why he has put on weight and he has got a pot belly. And you know, in our society, we say pot belly is a sign of prosperity. But according to rheumatologists, pot belly is the end of prosperity, because you have to keep on going to doctors, a lot of money you have to pay doctors for their consultation fees. Drugs are expensive, that your bank account is there's a link, your bank is linked, account linked with the consultant's bank account, and your money starts rolling to that side. So all the men, if you have a pot belly, I think you should do something to make it flat if you do not want to develop frequent backache. So that's important, look at them from the side. Just to show the arrangement of the spine, this is the arrangement of the spine when you have the ideal curve. You can see the facet joints there just touching each other. That's the foramen through which your nerve roots come out. It's very loose enough room. And this is the arrangement when there's an exaggerated curve. You can see the joints are jamming against each other. And you can see the foramina is very narrow, pinching on the nerve. And I have not shown the muscles and the ligaments. You can imagine how much the tissues are getting sort of jammed when your curve is exaggerated. So that's another important thing that you should look for in this patient from a side. Then, of course, you get them to stand on their heels. Today, neurologists tell us one of the best ways to assess the integrity of the L5 nerve root is to get them to stand on their heels, and you get them to stand on their toes, and that's a very good way of looking at L5 and S1. Then you do the spinal movements very quickly, flexion, extension, lateral flexion. Then you get them to walk. Walking again will show the spasms and the symmetry, a lot of information you can do. Then you invite them onto the couch, you put them supine, you perform the straight leg raising test. Of course, we look for the hip and knee joint examination. Sometimes hip problems too can be felt as low back pain. And if it's a young person, especially not in this lady, but if it's a young person, young man, particularly below the age of 40, I look for the sacral joints as well. No back pain examination is complete without doing the neurology of the lower limbs, because you know all your nerve roots come through the spaces between the vertebrae. So you have to have a good knowledge on the dermatomes of the lower lumbar nerve roots and the sacral nerve roots, and particularly you have to emphasize on L5S1. These are two nerve roots that get pinched in lumbar pathology, and the motor examination too you have to know. So I think as doctors, whether you're a GP or a clinician, you have to be very, very familiar with the clinical signs, particularly when the L5 and S1 root is involved. At least if you know these two, you'll be a good carer for people with low back pain. And all patients come with low back pain, particularly acute low back pain, you have to, even if they have no symptoms in their lower limbs, routinely, it won't take more than just 2 minutes to look for sensory motor features of evidence of disturbance of L5-S1 nerve root. Then, of course, you examine the lower limb pulses, and if the history tells you that he has got loss of weight, loss of appetite, if the patient looks as feels very ill, feels very tired, and if you think there's something else is happening, always examine the abdomen for liver, spleen, and also the para-aortic lymph nodes. You look for all of these things. Then you roll the patient on the bed, put him face down, or what you call as a prone position, and from the mid-dorsal spine, by inch, you have to press from the middle and look for tenderness, which was done, and we were told that she had tenderness of the lower lumbar spine and in the sacroiliac region or the ligaments. That's from me for evaluation of low back pain. History and examination is extremely important for any doctor. Over to you.
Thank you very much for that very interesting, comprehensive information. Now, based on the information you received, would you like to comment on the management? As to the management, how would you move forward? Any comments, any views, any thoughts? You know the history, the examination has been done. Now, for the management aspect, how would you move forward?
I think we must first assess the risk factors he already has. One thing that I noted is the overweight. So we must think of giving a suggestion how to reduce the weight to the optimum level.
Very true.
It may go a long way in recurrence.
Right.
And as I told about the posture, the day-to-day activities, how they sit and stand and bend and do any work. Another thing I want to vary from Lalit, that there's a big dilemma regarding lying on the bed. Earlier, I remember years ago, they asked to lie down on the flat board. Now they say it's wrong because they have a curve and they have to lie on a normal size mattress with one below. Even if there's any back pain, some people say, no, mom, what have you got to say about it? Posture?
I think I'll be coming to that slide.
Yeah.
I will describe.
Okay, yeah.
Okay, because you know you have to tell all that
Yeah,
to your
okay.
patient.
Fine.
Another thing that I find is she is overworked. So you might have a discussion with the husband
Right.
and how they can share the work and especially taking the children up and down. That's all comes to my mind.
Thank you very much. That's excellent. Any more takers? Anything else you want to? Okay, I will just share as to my management plan so that Dr. Lalit as well as the audience can comment on it, which will make sure that I will be managing my backache patients better from tomorrow. No investigations were done as it looked a lumbosacral sprain. I explained to her the possible reason for the pain, reassured her, and the treatment given by me was as follows: piroxicam, omeprazole, and diazepam. The doses are given there. Advice on lifestyle modification was given as follows: not to bend to pick up things, but to squat and get it. Use a hard bed to sleep, or use a mat with one pillow to sleep on the ground. Use a shower to bathe. If she is using a bucket of water, then use a low stool so that she doesn't bend when she takes a bath. The other advice given was as follows: something in regard to weight reduction by reducing on her high calorie consumption in her diet, but then I didn't touch on it in great detail because she is in severe pain and this is not the point of time for me to talk about at this point of time less relevant aspects because she wants to be pain free, right? So I thought I will keep it for the next subsequent visit. I advise to get some home help if possible, as Dr. Mota said. And I also advise to bring her husband if possible to explain about her sickness and if possible to request for sharing of her work responsibilities, which I thought was very important because he is the only adult at home other than the 3 children. So I was a little worried about the husband not appearing on the scene. So I just mentioned to her to bring the husband and come. I also wanted to talk about exercise because weight reduction means diet and exercise. Again, for obvious reasons, I didn't want to touch on it. I reserved it for the subsequent visit. And a review was planned in 5 days' time. Again to Dr. Lalit Vijayaratna as to his comments on whatever has been discussed up to now.
Thank you, Shekhar. Yes. Yes, at this point, well, we have taken a good history, we examined the patient, extracted a lot of information. And if I summarize, at this point, I will try to put my information in front of me. If I summarize here, we have a 45-year-old obese lady with backache, acute backache, short duration, with tenderness of the lower spine. The neurology or the lower limbs are normal. With those information in front of me, I'll, like any one of you, I like to work out a differential diagnosis because, remind you again, there are no red flag signs. I'll always check with that. There are no red flag signs, so now I can move it forward. That means I can keep this patient with me and manage this patient because always as a GP, I know when you are confronted with such a situation, you always ask yourself, am I going to keep or am I going to refer? Can I manage or should I give over? Still, you can manage because there are no red flags. And it's acute backache for 3 days. So this will be my differential diagnosis with information in front of me. Prolapsed inferior disc is out because neither in the history or in the examination there was evidence of nerve root involvement. And osteoporotic fractures was very unlikely because the pain is usually in the lower dorsal, and the characteristic thing is that the pain radiates sort of like a girdle or like a tape. And they also complain that changing posture is a lot of pain and a lot of other factors are there. So it clearly focuses on the first category, the mechanical type, or what we call is just a strain of the soft tissues of the spine. I'm quite happy. I will not perform any investigations at this moment because it was necessary. And my management plan, or what I would expect my general practitioner or just to follow this, I take them. reassurance is very important. I don't know whether how many of y'all have suffered on low back pain. I myself have suffered about 5 years back, and I have to tell you, even as a rheumatologist, it's very scary. Very scary. Because you can't see, sometimes you can't bend, and all sorts of things. So I can imagine what a day people are like. And when I talk to my two decades, I know how much they are distressed. So each move, your body language, your question, everything should be reassured. You should never sort of indicate to the patient that you are suspecting. You always look very carefully into your eyes. Always your language, your mannerism, everything should be very soft, very gentle, and reassuring. Just to quote some evidence, you have to remember that 90% of different many patients with low back pain may come to recovery treatments. That's good news for you, which means that you can manage patients at all. You don't need tips and patients to us. And but certain statement is what I'm quoting an article which came sometime back in the BMJ. Patients who have high expectations for recovery had a good outcome. So your role should be to give a lot of hope to the patient. Allay or remove all the anxieties, all the suspicions, fears. You have to do that. Even in my limited practice, I have seen when the patient has a positive outlook, they do very well. So reassurance is very important. Every minute you have to reassure them. Drugs, yes, these are drugs we use, and here I think the correct drugs are used. NSAIDs, and I'll come to it in a moment. Another important point is discourage bed rest. I don't know how much you have the experience. In my experience, sometimes sad to say, some people consult me and they say, Doctor, I have backache. I came to get a medical certificate. Nothing. They just say, I came to get a medical. I want 2 weeks leave. So we have to be very careful, because today as a lot of researchers say that low back pain is, for low back pain, bed rest is not necessary unless you have those red flag features. I'll talk about it in a moment. So therefore, I think you have to sit with this patient because she's very worried. And we know she has to do all the work by herself. So I'm sure she might think, now who is going to look after my children? Who is going to tidy my house? So you can say, whatever you can do within your parents' limits, you do it. If anything gives pain, stop that. So you must say, don't stay in bed, but do your activities, what you have been doing within our normal limits, which again will give her some hope and confidence, and also give a lot of positive thoughts. She's in a lot of pain, but I think because always these patients always ask us why. Am I correct? Why did I get a doctor? My next door lady is fatter than me. She didn't have any backache. She's going to play tennis also. Why is it only me? They always ask. I don't know. I have a lot of experience with my pain. They always, why only me? They always ask. So I say, I can't answer that question, why it's only you, but you have got it. So you have to, I think, a little bit of, as you said, I will not waste a lot of time, but just to make her understand that posture plays a role, and that is a reason, so that whatever fear she has will be removed. So I'll give a little bit, I'll talk a little bit about the posture. And because she has even a lady who have been doing a lot of work at home, no help, so quickly I will show some pictures what I have with me. I'll talk to her a little bit about the correct posture of standing. I don't want to go into detail. I'll show some pictures and say, this is how you should do, and I will tell you, look at that. See what's happening to your spine, getting curved, and that can cause low back pain, just to make her understand the importance of posture in low back pain as a cause and also as a preventive and as a treatment measure. She's a lady who does a lot of work seated. She has to sew. She has a lot of work seated. Take the homework of the children, do the kids' work, so she does a lot of seating. Lying down, I think you asked me about lying down. Well, again, what we recommend now is the mattress should not be sagging, so that when you lie down, the spine should be straight. So if you don't need to sleep on a plank or a hard surface, it's very uncomfortable. That will, disturb the patient more. So you can have a mattress. Whatever mattress you are having should not sag down. It should not sort of bend down. The spine should be fairly straight. That's what I say. So very thick foam rubber mattresses are bad because they are very soft. It just sags down because you know your heavy area is the buttock area. So if you have a very thick mattress, your buttock area sags down. That means your whole spine is like that. Means you're like that for about 4 hours. If you stay like that, even for 5 minutes, you get a backache. You know that. When you watch a match in awkward posture, you get a backache. So routinely, I tell all my patients, because now they are to show that people who sleep on firm mattresses get less low back pain. So I think they should go to the school children as well. because all today when people talk about beds, they talk about the thickness of the mattress. So routinely they think a thin mattress will be more back friendly. And if they have back pain, people have gone to research has shown that if you sleep with 2 pillows under the knee with the knees a little bit bent, all our back structures are relaxed, so that the tension, the jamming, everything gets quite relaxed if you keep 2 pillows under the knee. So if you are a person who likes to sleep looking up, you can advise him to use a very thin pillow and having 2 pillows there. That will relax all the structures, because in this lady, she had a lot of tenderness in the lower lumbar region, which means her fascia, her ligaments, everything's jammed and they are loaded. So this will ease off the load and that will relieve her. If it's a person who wants to sleep to a side, you know, all of us have our ways of sleeping, then you must always tell them to, please remember, my topic is low back pain and not neck pain, but remember, this is the correct art of sleeping. Always remember the pillow must cushion this gap between the neck and the shoulder, right? And also when you are sleeping, if you can keep 1 or 2 pillows between your legs so that your hips are not too much interrotated, keep the thighs straight, that also get a relief. So you can just teach her about the correct postures or pain relieving postures, which will give her a lot of relief. A lot of things, just a little bit of education about the correct way of lifting things. And of course, I cannot overemphasize the importance of losing weight. People ask for physiotherapy. We do not recommend physiotherapy in the acute stage, but nowadays many people do not use. But when I recall my kid days in the 60s and 70s, I can remember my uncles and granduncles, all of them had a hot water bottle. And today, again, research say that it may be helpful to relieve pain. So if you have now I don't think whether you can buy these things. This will be a good measure to ease off your pain. Coming back to the management, which I'll give about a few comments. I think we have to, I'll pay a lot of attention to reassurance, and I will tell the patient, even if she doesn't ask, I'll say, go back and do whatever work you can do within your capacity. I'll say not to be in bed. Because sorry, I didn't bring that slide. There are slides to show that people who do bed rest or who spend time, most of the time of the day, resting in bed with acute back pain have a longer period of recovery than people who do their day-to-day work. So bed rest in acute backache without those red flag problems. Can you remember the red flag problems? Yes. If you put them into bed, you are in fact doing more harm to them. It's going to be a big problem. It's like putting a collar to neck pain. Sometimes you can't remove the collar. So I will always discourage bed rest. Treatment. This is the treatment which was given. I would prefer to add a paracetamol, because there is some evidence to show that when you add paracetamol to the NSAID, that gives a better analgesic effect. Piroxicam, again, I'm a little bit reluctant because she's an obese lady, and obese people can have things like reflux and they can have problems. I will use a different NSAID in that sense. But I will always add a paracetamol. Diazepam, again, you can remember I told you how to put the patient prone and feel the back. You have to feel the erector spinae. If you feel, when you keep your palms and slowly come down, sometimes you can feel very hard areas which are tender. This is muscle spasms. If my patient has got evidence of muscle spasms, yes, I'll be using diazepam. Otherwise, I will be reluctant to use that, because that sometimes can make us sleepy and keep in bed. And that can give a sense of ill health. If you talk to people on diazepam, sometimes they feel ill. And because always you must give the positive feeling for this person. I will avoid diazepam unless she has got a lot of muscle spasms in my clinical evaluation. This is what was given. Yes, yes.
Applications,
yes,
and
you can do that. Yes,
especially in the Sri Lankan.
Yes, if there's a lot of local tenderness, you can do that. Like the hot water bottle, you can keep a hot water bottle. You can ferment with some warm water, wipe the water, apply some local. There's diclofenac gel, which is very good. Apply that and give a little massaging. That is good if there's a lot of local tenderness. I
feel in our Sri Lankan practices they
like that. They want that.
Yes.
Very true. I do agree. Thank you, Dr. Hanifa. Yes. Again, now sleeping on the ground is a bit of a problem, because if you just for a moment think, See, if I want to go to the ground, say now I want to sleep on the ground, there's nothing wrong with the ground. The problem is the transfer. When you transfer from the standing to the lying down position on the ground, you have to bend your spine. And sometimes that can be harmful to the spine. So therefore, they say sleeping on the ground is not a good recommendation because of that reason, because you have to bend in your toes and then you have to slide onto the floor. During the process of transfer, you can sometimes load your structures and cause more back pain. So therefore, people come and ask me, I discourage them sleeping on the ground. Then bathing, yes, again, I think I'm very happy, Dr. Shekhar, you mentioned about using a bucket to bathe, but you must ask me use a very light cup. Because again, research has shown that if you sit and bend and lift something, there's enormous amount of pressure developing in the spine. I couldn't bring this slide, I'm sorry. About 15 years back in the United States, there was a physicist who coupled with a rheumatologist and did some research. What he did was he inserted some small needles and recorded the pressure differences or the pressure difference of the spine, lumbar spine at various levels in various activities. And it was very interesting to note that the highest pressure which would develop in the spine is when you try to sit and lift something. So therefore, if you are sitting and taking a bath, ideally someone should pour water to you, or you must use a very light cup. Because bending and twisting is a very important cause of low back pain, because bending and twisting can damage your structure. She already has a lot of tenderness, so I will be very careful to advise the method of shower will be the best, but if not, I'll have to address that issue as well. Over to you.
Thanks again. Now for the follow-up visit. In 5 days' time, she comes back, says the lower back ache is very much better, very mild pain persists. The treatment given by me at that point of time was paracetamol, 2 tablets 3 times daily for 5 days. I again spoke to her about the lifestyle modifications just to make her remember what was told during the last visit. And I spoke a little in detail about the weight reduction and advised her to walk when possible, then using a 3-wheeler. Spoke of the importance of weight reduction, which would be beneficial in reducing the strain on her back. And she reports that her younger sister from village has come to help her with the housework. That was a heartening bit of information for me. But then the worrying thing is husband still missing from the scene. Over to you, Dr. Lalit.
Thank you. Yes, I quite agree with Dr. Shekhar at this point, since she has less pain.
Sir,
minimal.
may I interrupt
yes,
you? Again? Now, in the interim, this 5-day visit, what steps did you take to safety net? If something went wrong and your treatment didn't work, in your education, did you tell her anything specific? Say he spoke, Dr. Lalit Vijayaratne has spoken about the red flags and so on.
Right.
So what in case that developed in the interim period before this visit?
Yeah.
Now as a primary care physician, I think it's our duty in the education process to mention these things very specifically. So in that context, I'm wondering whether if you got the pain, do these investigations and come to me, or some advice like that.
Normally in my practice, what I normally used to do is, always I used to say, if by some chance you are not getting better, please get back to me or call me within about 2 days or 3 days time. So is that what you are meaning?
I think, yeah, that is very important to, I think, to emphasize to this audience.
Point taken.
And also, I think what you can tell the patient is that if her pain gets worse, or in addition, if you develop any symptoms, better not, I will not mention the long list because she can't remember. I'll say any change, not only getting worse, any change, please come back to us, or you can give your phone number, then she can call you. Yes, yes, point taken, I do agree.
Now that we are on safety issues, I think NSAIDs, if you are putting a patient on NSAIDs, you have to look at a lot of aspects. Starting with, of course, comorbidities which she doesn't have, but any medication which she is on. Is she an asthmatic? Does she have hypertension? I mean, you need to highlight those areas. And also how you're taking the medicine. That it should be taken after meals, followed by a glass of water, and not to lie down for about an hour after that. And when they come back, like the safety netting that Hanifa was talking about, to warn them about, passing dark-colored stools. Right. So to keep a lookout on those things.
Yeah, I think those are the routine things that we should mention, yes. Yes. So again, I will re-emphasize the importance of, since she has less pain, now she is in a more receptive mood to take your advice. So you talk a lot about the postural discipline and preventive measures. Coming back to this, I personally feel that she doesn't need paracetamol because she's much better now. Because I have the feeling when you prescribe something to a patient, they always have the feeling that they are still ill. So since she says she has hardly any pain or little pain, I will say stop the drugs I gave you, but you can take paracetamol only if you have the pain on a PRN basis. That will give the patient a sense of confidence that she's recovering. Because always my objective, a lot of positive thoughts that she's in the correct direction. So I will just keep it if necessary only. Over to you.
Can I come in on that one? We are in a competitive field. General practice is in the private sector. We have got so many of our colleagues who are practicing, and there is nothing to prevent our patients from walking across and taking treatment from another colleague. Nothing wrong in that, but this is also a concern that maybe SOS will solve it. But I have had a lot of these problems. The patient is quite dissatisfied. I mean, I'm not saying that we should encourage medication, but this is a small aspect of general practice.
Thank you. Now patient returns to the clinic after about a month, and she says that she was just on and off having very, very mild pain. She didn't take it very serious, but then what has happened has now, for the last day or so, she has got severe pain, and this time still the husband is missing, has come with the neighbor. She is in severe pain and says the pain radiates down the right leg. She also says she has numbness of the right calf region. The SLR was positive on the right side. The reflexes were normal, and there was no sensory loss in both legs, although she said that there was subjective numbness. I couldn't find any sensory loss. No bowel or bladder symptoms. During the consultation, she says the sweet sister who had come to help her has gone back to the village, and she is again now stuck with all the work. She is now terribly distressed, and I couldn't resist asking the question about the husband, and she says husband has gone outstation 2 days back, again on work. Because this husband is always at the back of my mind for the simple reason, because he has not come at all, and I am wondering now whether there is a strained relationship, and if so, I am at a big loss, because she is with 3 teenagers, or 1 teenager and I think 2 young children, all the work on her head, and there is no one to help her. So I am eagerly awaiting the arrival of the husband for me to talk to him and give him some information as to how he could help the wife, but then still the man is missing. Over to you, Dr. Lally.
I'm not sure whether I'm interrupting too often, but I can't help but comment on the husband, because the husband in general practice is a red flag per se. If a husband comes with the wife, I know there's real trouble. So I don't know what the others have to say about it, but I have found that the husband is usually red flag, the presence of the husband actually.
What's the trouble you see, Dr. Eugene?
Several things actually. One is that it's a serious matter. The husband coming, the mother-in-law coming with the patient means it's getting serious. So
what way
if the husband is not there, No, that means it's causing a lot of upheaval at home. Right? There are a lot of problems at home, and husband is finding that he can't go for work and things like that. Of course, if the mother comes, there is genuine concern. My apologies to all husbands anyway.
Thank you very much. I learned something from you. Yes. So again, to remind you, this patient comes after 1 month, 4 weeks after the initial presentation. And to summarize her problem, she has severe backache. This time the pattern has changed. That's what I told you initially. When you analyze the pain, the pattern is very important. And this time she says the pain shoots down her right leg. She has numbness and pain on the right calf, a very important symptom. Remember, pain in the right calf, of course, that's a non-differential diagnosis. Don't forget, S1 radiculopathy can commonly present as pain in the calf. So if you have a patient calf muscle pain, of course, you look for peripheral pulses, you think of leptospiral, non-differential diagnosis there. But if the patient keeps on coming to you, always think of S1 radiculopathy. And can you remember my previous slide? Do a good neurological assessment. You are going to find some signs there. Think of the S1 radiculopathy and the lumbar spine in people who come with chronic or acute calf pain. And she has a positive SLR to this time on the right side, which all focuses on S1 nerve root. So she has what we call as a S1 nerve root radiculopathy. Again, I want to remind you, no matter how frequently the patient comes to, any change in the patient's pain pattern or clinical picture, always you must do a reassessment, history, examination, and always you must ask yourself, how sure am I that the first category is not there? This is just like PUO. You have a pyrexia of unknown origin. Every time you go, you have to take a history. So again, you go through that and you make sure that the serious causes are no more there. Make sure the red flags are no more. You retake the history and make sure the red flag, and this patient didn't have any other red flag features. And then you have to ask yourself as a GP, now here she has come with a radiculopathy, am I going to keep this patient? That's your first question. Or am I going to refer the patient? Today, there are guidelines very clearly stated as to what type of patient who comes with the radiculopathy or sciatica needs referral. I don't want to go through the whole list. If any of these things are present, I think you should not keep the patient. Please give a call to the clinician, because the patient should be cared very carefully. You can't ask the patient to go whenever you can. If I am a GP, I will give a call to a clinician who has interest on backache and get the patient transferred immediately to a clinician that has to see the patient on that very particular day and take over the patient. If none of those things are there, which was not present in our patient, you can still go ahead. So what will I do? I will continue my NSAIDs, or I will want my GP to continue with my NSAIDs, since she has a clear-cut evidence of radiculopathy. Today, there's evidence to suggest that gabapentin and tricyclic can sometimes, not always, not a very clear-cut proof though, but there's some evidence emerging that gabapentin might have a role. So if she can tolerate, I might try that, because there's a radiculopathy. Of course, continue the same things. And physiotherapy, I will not do much, but I'll talk to her about posture discipline, which I have been doing before. Go to you.
Okay then, based on the information you received from Dr. Lalit and from the case scenario, what would you be doing next in regard to this patient? Any takers?
I would, of course, do the facilitate, since it's a partnership between shared care, what we call, do some investigations which would facilitate the consultant or whoever I'm sending to have better clinical judgment of the patient. So probably some investigations and a proper referral letter with my findings at the 2 occasions. With those 2, I'd probably ask for a second opinion.
Thank you. Anything else? Okay. What I did was as follows: explain the possible cause of the pain and told her that she needs some investigations this time. After her consent, I did a full blood count, ESR, urine FR, and X-ray of the lumbosacral spine, AP and lateral. And I gave the following treatment: diclofenac, PCM, omeprazole, and diazepam. I advised strict bed rest and asked her, again the husband comes, Ask her to bring her husband next time. I won't let him go because I am very anxious. He is the only savior for me to help that poor wife. Patient returns with test results. The reports were normal in 2 days' time, and there you are, the husband has accompanied her. I may be wrong, but from the way he was bringing her into the room and the body language, I thought the relationship was fairly okay, which was a very happy thing for me. So as I said, the reports came back as normal, and as the pain was only minimally reduced with rest and NSAIDs, I was just thinking of MRI of lumbar spine. After negotiating with the patient and husband, the option of referring to NHSL was given if they cannot afford, but they preferred to do the MRI to avoid the delay in getting an MRI done in the state sector. So that was done, and the results are there on the screen. Mild posterior right paramedian protrusion of L5-S1 disc encroaching into the spinal canal, causing mild compression of the right S1 nerve root in the exit foramen. Following this, as suggested by Dr. Hanifa, the patient was referred to NHSL as they cannot afford further management in the private sector with a proper referral letter, and spoke to the husband and advised him on the supportive role he need to play. Over to you, Dr. Lal.
So remind you again, this patient comes with acute backache with S1 radiculopathy, and some investigations are given. She comes back after 2 days. And the important thing is she says she's not worse though. She remains the same. That's the important point for me. Right. Now again, at this point, today is all evidence I'm quoting, but even up to date, there's a lot of information to say that although patients with acute radiculopathy, looks sometimes, although they look scary, most of them, 70% is, I thought, a good figure, recover within 4 weeks. This should be at the back of your mind. It's not a dangerous condition as you think. It's very painful. It's very, sometimes you always feel, should I refer the patient? But remember that the recovery is very good. So if I were you, I will still, since there are no red flags, and since she claimed that still she feels the same, and 2 days is just a very short period to assess a patient. She has not progressed. I'll, at least for 1 month, I will, as a GP, if I was a GP, I will keep the patient with me with the same management. And again, I'm quoting this, which was published about 8 years back, the bed value of bed rest. Just to remind you that bed rest is not recommended for all patients with sciatica. Please remember that. So still, I will tell her, you can do a little bit of work though, but don't spend the whole day in bed. I'll always remind about that. Commenting on that, I think I am not very happy to say strict bed rest, because I think if the patient can move about, she can be in bed, she can walk about. The word strict, I will not emphasize much, because I think that will give a feeling of, again, that we are suspecting something very dangerous. Unless you are going to send the patient, if there's a red flag, I will say strict bed rest. Otherwise, I'll just say, try to do some work within your capacity, but be active. That's the word I'll be giving to her always. Diazepam, at this point, I will prefer gabapentin or tricycline than diazepam, because she has a definite radiculopathy in the clinical evaluation. So I will go ahead with that, and after 1 month, if there's no response, what I will do is, I think I will transfer this patient to a unit where something else can be done. But again, remind you at this stage, in about 1 or 2 weeks, if the pain is not getting better, I think still it's better for you to refer, and as Dr. Hanifa mentioned, way to tie up with a clinician, and you can have a, that's what I will do. If this patient is sent to me, I will sort of get back to and see, just manage the patient. But I want to see the patient in 1 month's time, and if the patient is not better or getting worse, I might think of a epidural injection. Now again, there's a lot of views about epidural injections, but The sad story is that although people talk about it and give epidural injections, there's not much evidence to suggest that the long-term effects are good. And a lot of research says that if you have two groups, one in epidural, the other just be conservative, at the end of 2 months, it is more or less the same. So as a symptomatic measure, yes, you can, just to make the patient a little bit more, give more relief. Other than that, it hasn't got much effect on the pathology. That's what the research says. Then if things are bad, I'll think of surgery. When will I refer to a surgeon? If the person's neurological signs are progressing. That's why this type of patients, if they are in a lot of severe pain, or if they don't recover in 1 month, I will admit them to my ward simply because I want to analyze them. The two main things I'll be doing in my daily ward round, and what I'll direct my junior medical staff is they have to maintain very careful daily notes. Notes on admission every day. They have to ask for pain, and the patient is intelligent enough. You can give a visual analog scale or just say better, worse, same. Those 3 words always in daily notes have to be mentioned. Pain, arrow, is it better, is it same or worse? That has to be there. And they have to do a very quick neurological assessment. Because if more nerve roots are getting involved, immediately I'll hand over the patient to a surgeon because something serious is happening. Or if bilateral involvement is, if roots are getting on both sides, that's another indication. So I will always do the neuro assessment, and every day when I go to my ward, I myself will check for these 2. And these 2 will allow me to decide whether I'm going to keep the patient with me or send the patient to a surgeon. Today, there are different indications for surgery, so presence of any of these, some of them were given under the red flags as well. I will always get my surgical colleagues to join hands with me and help me with it. And commenting about the patient, about the X-ray. You had done an X-ray, I think, within a few days of the acute presentation. This again, and also MRI. I think for the last few years, the rheumatology colleges all over the world and the radial colleges were having a lot of debate. And last 2 years back, there was a consensus document which came from the American College of Radiology, which the American College of Rheumatology also approved. And today there are very clear-cut indications for imaging a spine in a person who comes to with acute low back pain. And some of them are the red flag things you saw. So taking these into consideration, I will not be doing X-ray, but again from the general practitioner's point of view, I think the patient is anxious, the husband is anxious. So if you feel that something has to be done, you will do it. But otherwise, if you go to purely on the research grounds, there's nothing that you can achieve, they say, unless these are present in the patients who come to you in the first 1 month. Earlier, there was a view that MRI should be done to reassure the patients, because even we thought at one time, when patients come to us and if you can tell them, look at this MRI here, it says nothing, don't worry, that it will give a lot of positive thoughts. But again, 5 years back, there was some research to show that that also was not very helpful. So you have to be a little bit more selective, particularly when you're doing MRI, because that's very costly. And in the National Hospital, they are very strict now. I have only 2 MRIs for the whole month. So it's a bit tough for me as well, because you can imagine, because this is a free medical service we have, and the government has to bear the cost. So it's very tough in the National Hospital as well. Over to you.
So the patient has been sent to the NHSL, and there has been no feedback from the patient yet, as the referral was made only a few weeks back. At this point, I like to bring up a problem faced by many of us, the GPs, which I have heard from even my fellow GPs, as well as it has been experienced by me from time to time. This is regarding back referral. We come across many situations where when we refer patients to secondary and tertiary care, to consultants, we don't get any feedback. This puts us in a very difficult and embarrassing situation, as we just don't know what the follow-up plan the consultant has decided for this patient, as well as what is the role he wants me to play to ensure better care for the patient. I thought I should raise this point here because Dr. Lalit Vijayaratne is on the other side of the table. So he will be able to tell his views as to what he feels about it. As well as the other reason is because he is a person who has lots and lots of faith in regard to the concept of joint care. So I thought this is a best opportunity for me to get his opinion on this. Over to you, Dr. Lal.
Thank you, Dr. Shekhar, for raising this issue. It's a very embarrassing situation for me also, because to be very honest, sometimes we find very difficult to send a note or letter back to you. And we have discussed this with our other colleagues also. I think the biggest problem we have is sometimes the time constraints, because we have our clinics are, the numbers are very big. And we have to do a lot of work single-handed. And as you know, in the developed world, they have the dictaphones and things like that. But I don't think any of these things are excuses. What I personally do is, whenever a person comes to me with a letter from a general practitioner, I don't know whether I'm doing the correct thing. I always ask, what did this doctor tell you? Now, does he want a letter from you, from me, or what did he say? So when the patient says, no, doctor, no, nothing to worry, your treatment, I'm very happy, then I don't give a letter. So I know I'm doing the wrong thing. I think that clears my conscience, you know. So I do agree that, particularly when we come to topics like this, I think there should be a shared role. That is the only way we can address this issue in an effective manner. And I think what I thought was, in fact, when we were discussing this over the phone, I was telling Dr. Shekhar, what I could suggest to my colleagues is I'll try to print out a little standard form, because writing a letter again takes time, because I have to write a letter and I say, my dear Dr. Chandrasekhar, I'll have to wish you for the new year. A lot of things have to go in. I mean, I feel a bit rude to say I can't write. That's how we have been taught to write letters. A lot of formalities have to go in. So those little decorations we can't do. So what I thought the easy way out is I'll try to, with my other friends, I will try to prepare a standard little form where you have to only fill the blanks. The patient's name, age, the date I saw, then you know how long the patient took to come to me. My diagnosis or differential diagnosis, what I have done, the drugs I'll say refer to my prescription, the drug sheet is there. If I've done something else, I'll just put in my titles, posture discipline, avoid bed rest, something like that. And I'll have about another 3 or 4 lines on future management, which I will be addressing you. Are you happy with that? I think that will be a very short thing. And my mobile number will be there, so you can always send these things to call me if you have any further queries. Or else what you can do is, in a very serious situation where you really want to know something, I'm happy to do it personally. If you can give your mobile number, I can call you back. It's easy for me in that way, because I have assessed my patient, everything is in my mind. It's easy for me to give you a call from my mobile and tell you that so and so is with me, because I'm fresh with my knowledge. Because what you can write is also limited, isn't it? So depending on the situation, I can even do that. If you can, if you can just say call my mobile. But the time I'll be calling you will be between 5 and 11 p.m. I don't know if it will be at 10 o'clock even. So if you don't mind, I'll give you a call. So that way we could do. And I'm glad that you raised this. Can I take it up with my friends also about the back referral, which I think is a must. So that's all. Thank you very much.
Can I
Yes,
say
please.
a few things about this? I think this is a very tough problem for us, because when we refer patients to a specialist, I mean, state sector, yes, I mean, I appreciate that there's a lot of work, and our colleagues in the state sector are overworked and they have no time to refer back. But very often, I mean, you have diagnosis cards and things like that coming from the state sector. But when it happens in the private sector, I think it's a bit serious, because, I mean, we also have to spend some time writing letters. We are also busy, and we also like to write nice letters. And on the other hand, there are specialists who reply very detailed, and very good letters, and we are educated, and our patients are educated. Because I think a common thing that all of us have is, when the patient comes back, after having referred the patient to the specialist, the patient wants us to give an interpretation of what the specialist has done. And I very often tell them, look, I don't know anything more. That is why I referred you to the specialist. No, but how can we ask the specialist, now you must tell us what we have got to do? So I think for the sake of patient care, it's very, very important. And I think for the safety of both the GP as well as the specialist, I think these aspect that is missed altogether, that the specialist does not realize that the GP has a protective role even for the specialist. And if there is the communication is poor, you are at risk a bit. So yeah, I think we need to look at this a little bit more seriously, because I think it's the exception rather than now. Lalit, of course, I have had no problem. All the referrals come back. The other thing that worries me is whether what we write to the specialist is legible. I'm quite sure my handwriting is not readable, and both the letter that comes back also is not readable. So maybe that there is a side to that also. Okay, thanks.
Anyway, I think we have heard the opinion from both sides of the table, so I think you will be in a better position to do your job from tomorrow. That brings us to the end of a very interesting interactive session. I hope you all benefited from this. There is a very important message, a relevant message from the sponsors, but before that, no learning teaching session is complete if it is not evaluated. We have sent around an evaluation form. Please take a few minutes of your valuable time to fill that and return it to us, which would help us to develop or better our future sessions. Before the sponsors come into the scene, I would like to call upon Dr. Lalit Vijayaratna to share his views on today's session. Thanks a lot from my side.